So next we will be doing infectious disease. How was the class, doctors?
The session was very nice, very interactive.
Good. Interaction is always good.
Yeah, it makes you feel like you're doing a round.
Yeah, that's good. Okay, so we will take another round now in the septic ICU. Okay.
Okay.
So let's begin. A 65-year-old woman with a bad history. She's diabetic. She has come to you with in ICU with fever, hypotension, and confusion. Okay. Anybody can tell me what is quick SOFA? What is quick SOFA? Quick SOFA.
Say
It's an
hypotension, respiratory tachypnea, and altered mental status.
Yes, very good. So what all my patient has? So she's 65. She has diabetes. She's in the ICU. She is febrile. She's hypotensive and she's confused. So what do you think? Quick SOFA is almost positive. 2 out of 3 is mentioned, but tachypnea is not mentioned. I'll add it for you. She is breathing fast at 35 per minute. So all 3 are positive now. So what does this patient have? Quick SOFA 3/3. What is the leading differential diagnosis?
Sepsis.
What kind of sepsis? Sepsis is TLC either increased or decreased. What is sepsis? What does this patient have?
Diabetic septic foot.
Fever.
This patient has septic shock. The management of sepsis and septic shock are different. Okay?
Yeah.
He was recently discharged from the hospital after a surgery for diabetic foot infection. So she is a type 4 patient. So can you tell me what is type 1, 2, 3, 4 patient? So type 1 patient is patient who has come from community. Type 2 patient is patient who has stayed in the hospital for less than 3 days in the last 2 weeks. So type 3 patient is the patient who was in the hospital for at least 1 week. And the patient type 4 is the patient who has come to your hospital from some other hospital and has been in an ICU. Okay. So this patient is type 3 or type 4 patient. The patient was already in the hospital, discharged after a surgery for diabetic foot. She's febrile at 39. BP is 85/50. She has tachycardia. I've told you she's tachypneic also. Blood cultures are positive for gram-negative bacilli. Okay, this seems to be India. Because if it was UK, it would be gram positive. But then she has gram-negative bacilli positive. What will you do?
Meropenem.
1 hour bundle. You mean the antibiotic choice?
Yes. So somebody said sepsis and somebody said septic shock.
But yeah, doctor, here she hasn't received fluid yet.
Yeah, that is okay. The question is on most appropriate initial antibiotic therapy.
Meropenem.
It is not the next best step. It is the antibiotic.
I mean, like you said, she's septic shock. How come she like? Should I wait and?
So okay, very good question. But you have to see the question in the context in which it is being asked. The patient was already operated for diabetic foot infection. She definitely has an uncontrolled diabetes. She has come to the hospital in confused state. And she has hypotension. And she has fever. Agreed. Even if you give fluids to this patient, what will be the choice of antibiotic in this patient? Will it be piperacillin tazobactam or will it be meropenem?
Meropenem.
better to start with meropenem.
Yes. And why are we starting with meropenem? Because this patient has very high chances of going into septic shock if she is not in septic shock. If I agree that the fluid has not been given, even if we give the fluids, still this patient will definitely need a higher stage antibiotic to be managed at this stage. Okay, let me just reframe this question for you. This is a 65-year-old lady. Okay, make it 68-year-old lady. She has come in confused state, BP of 80/60. She is diabetic, okay, all right. And respiratory rate of 40. Urea creat elevated. Let us say creat is like 1.6, urea is like 52. And yeah, that is what it is. So you do a chest x-ray and you find out, fair enough, she has right lobar consolidation. So what does this patient have? Number one, diagnosis.
What did you say, doctor?
What is the diagnosis?
Community acquired pneumonia.
So she has community acquired pneumonia. And what else? Where should we, how should we manage this patient in OPD, IPD, ICU?
ICU.
Why
I
ICU?
Because
think the curve 65 is high.
in severe respiratory distress.
So curve 65 is high. How high?
Confused. Urea, I've not seen urea. Urea is 52, which is more than 20, I think more than 50. And hypotension and the age more than 65.
So we have a patient who has, by criteria, she has 100% chance of mortality. Theoretically, we say every alphabet is adding 25% of mortality. Sorry, 20% of mortality. So this patient has literally chances of 100% mortality. So what will be the drug of choice in this patient? Antibiotic.
Still meropenem also.
BL-BLI
So
with the
DS patient will need a BL-BLI combination plus
MRSA
80
coverage.
plus a macrolide.
macrolide.
For atypical coverage.
Yes. So we will have a macrolide or a respiratory fluoroquinolone, although it is not approved much these days. So macrolide and BL-BLI should be enough with IV fluids. Yes, if the patient does not respond and is also having other features of septic shock like high lactate, then the choice of antibiotic will shift to meropenem.
Doctor, what is BL-BLI? Sorry.
Okay. The BL-BLI is basically the thoracic BTS guideline, British Thoracic Society guidelines say that you need to give BL-BLI. That means a beta-lactam drug plus a beta-lactamase inhibitor. So the drugs will become piperacillin tazobactam, cefoperazone sulbactam, even augmentin, amoxicillin plus clavulanate. So these are all approved. But given that this patient has high curve 65, you will use higher drugs for management. Maybe you can use meropenem plus sulbactam nowadays because meropenem is beta-lactam, right? So you need a beta-lactam and beta-lactam inhibitor drug as well. Okay?
Okay.
So the choice of antibiotic, what is the concept in septicemia and septic shock? The concept is hit early, hit
hard.
Yes. So we are going to hit early and hit hard with the help of meropenem. Okay, let's see. So this is meropenem.
But why
Patient
not
likely,
piperacillin or tazobactam?
patient is in septic shock. In septic shock, it is not approved.
Is a broader coverage. I think anaerobes and the ESBL, E.
Yes.
coli, lazosine will not
So
work.
yeah,
if
this patient has gram-negative sepsis. And which are the possible gram-negative bacteria in patients who come in septic shock? They are usually Klebsiella pneumoniae. They are Acinetobacter, and they are Pseudomonas. Lesser chances of E. coli. Okay.
Okay.
So in given circumstances, piperacillin tazobactam is not going to work on any of these three. Fourth, it may work, but Klebsiella, Acinetobacter, Pseudomonas, piperacillin tazobactam may not work. So this patient is in septic shock due to gram-negative bacterial sepsis, possibly involving MDR organisms due to her recent hospitalization. Remember, I told you this is class 4 patient. Meropenem is a broad spectrum carbapenem effective against a wide range of gram-negative organism. So it will become choice of empiric therapy. Of course, you send the blood cultures and you send the wound swab culture from the diabetic foot. Plus you said urine culture. If she is intubated, take out the ET gram stain and culture as well, ET secretions. So after doing this, start the patient on meropenem. Any questions? Okay, next question. A 45-year-old male presents to emergency department with severe dyspnea, high fever and productive cough. He has a history of smoking and recent travel to a country with Legionella disease breakout. So a chest X-ray shows bilateral patchy infiltrates. Which of the following tests can you do to establish we need to confirm the diagnosis of Legionnaire's disease?
Urine, I think, urinary antigen.
See.
So this is a Legionella
Pneumonia.
pneumophila, yeah, Legionella pneumonia, and its confirmatory test is antigen on urinary test, urinary antigen. That is okay. So urinary antigen test. Legionella pneumophilia also can get a very typical situation about sodium. What happens to sodium?
Low.
Low. So what happens to this patient because of low sodium? This patient will also have, this patient will have patch in the X-ray. This patient's BP usually is good. It's like 100 by 60, 110 by 60 types. Their respiratory rate is increased. They are usually confused. And they are usually more than 65 years of age. But their BP are usually normal. Their creats are also normal. So this patient always usually falls in the category of 2 by 5 curve 65. But their confusion usually adds up to the complication and makes it 3 by 5. But their confusion can be due to hyponatremia. Is that clear?
Clear.
So these kind of pneumonias, that is why they are known as atypical pneumonia, because they do not conform to curve 65 so well. Okay? Is that clear?
Okay. Clear.
Next question.
Yes.
A 50-year-old woman. So basically what I was trying to say is, in normal routine pneumonia, curve 65 applies very well because the confusion is due to hypoxia, tachypnea, acidosis, lactates. But in case of Legionella, you may not find anything on X-ray also, but the patient is confused because of hyponatremia. That is important to understand. A 50-year-old woman is admitted to ICU with severe headache, photophobia, and neck stiffness. What does this mean?
Meningitis.
She is febrile. Blood pressure is 110 by 70. She is subjected to lumbar puncture, which shows cloudy CSF, high opening pressures, elevated TLC with neutrophil predominance, low glucose and high protein levels. Okay, what is the likely causative organism? Very basic question.
Streptococcus.
The answer is Streptococcus, most common organism. So Streptococcus pneumoniae is most common cause of bacterial meningitis in adults. CSF shows neutrophil predominance, low glucose, high protein, and diplococci.
Sir,
Or
in every, sir, I have one query.
flame-shaped cells. Yes.
Sir, in every case of suspected meningitis, should we give dexamethasone or in specific cases?
Okay, very good question. So why dexamethasone is given? First, if we understand this, we will get to know the answer.
Basically, that will decreases the neurological sequelae if we give along with antibiotic or before antibiotic.
How?
That will reduce the inflammation. That inflammation usually because of the bacterial activity.
So you said a very nice word, neurological sequelae of meningitis. So this is brain. I'm very bad at drawing, so please
Fine.
Don't mind that. Yeah, this is brain and this is the ventricular system. Now, when we are talking of meningitis, where is the infection? Can you tell me where is the infection? What is meningitis?
Meningitis.
Yeah, so it is basically swelling of meninges. We are lucky that there is a fluid which moves in those meninges, which is called CSF, and we can take it out and make diagnosis. But it may or may not give us anything because it is just meninges which are inflamed. And when meninges are inflamed, have you ever visited a medical college hostel where the paint is dropping because of rainfalls? Yes. So what happens is that this is a meninx and the paint drops down because of the infection into the CSF. That is why the proteins, they increase in the CSF. Now these proteins, what will they do is eventually they will plug the drainage of the CSF. So this drainage of the CSF, when it gets plugged, hydrocephalus will set in. And because the meninges are so close to the brain, the meninges release cytokines. There are blood vessels here which become vasculitic because of local inflammatory response. Vasculitis leads to formation of blood clots in the vessels, leading to microinfarcts. Then there is a nerve which travels on the both sides, is abducens. It has got the longest course. So along with trochlear nerve, what happens is abducens and trochlear sometimes they get compressed here when the brain swells up. When they get compressed, what happens is deafness happens because of the vestibulocochlear nerve involvement. And what also happens is lateral rectus palsy, sixth nerve palsy happens, leading to divergent squint. So the eye is fixed here. Oh, sorry, in the medial. So this is the eye. This is the, because the lateral rectus of this side is not working, so the eye stays on the inside. Now, can you see there is no direct bacterial involvement anywhere. Meninges happened, meningitis happened, and due to that cytokine release vasculitis happened. Because of the protein debris collection, CSF occlusion happened. Because of the long course of the nerves, the deafness happened, and the lateral rectal palsy happened. Now, all of this is because of single process, which is known as
Inflammation.
inflammation. So this is why dexamethasone is given. Not because it is treating meningitis, but it is treating inflammation and decreasing the sequelae. So it is imperative and very wise to give antibiotics first and then start the patient on dexamethasone. Many a times the patients who have a lot of headache, photophobia and neck rigidity, they also get settled after dexamethasone because meningeal irritability also decreases with steroids. But that does not mean that antibiotics will not be given. And remember, this is meningitis. Always remember, this is meningitis. If it was encephalitis, will you use steroids?
No.
Yes, we will not use, because they will lead to further deterioration of the brain. We may use steroids later. Why? Because like COVID, all the viruses which affect the neurological system, they hit it by an immunological mechanism later. That is 1 week or 10 days after. That is when steroids will come and play their role. Otherwise, in encephalitis, steroids have no role initially. But in meningitis, steroids along with antibiotics must be given to decrease the neurological complications. I have mentioned you all the neurological complications. So,
sir, should we continue the steroid for 4 days since it is recommended to give 4 days in a case of Streptococcus pneumonia? So what should be done if the culture report is weighted and the patient is, we have given a single shot along with antibiotics? Should we continue the steroid along with antibiotics, or we can skip?
Yes. See, the protocol is, nowadays, the protocol is when you have to take a CSF of a patient who has come with this picture, you either check for papilledema or get an MRI done first. And then you do a CSF. Once you do a CSF and the CSF tells you that this patient has a picture of pyogenic meningitis, there is no point in not giving steroids. Are you getting me?
Yeah, yes.
Even if the cultures are weighted, the CSF report suggesting that this patient has pyogenic meningitis, if you don't use steroids in this patient is bound to have neurological complications. Okay,
sir.
Does that answer your question? But
yes.
if the picture shows that patient has viral meningitis, then no point. Because this meningitis will very soon convert into encephalitis also. So yes, this brings me to one another point. The natural course of meningitis and encephalitis is that a patient, I can make these questions very interesting for you. For example, this patient who we treated for meningitis becomes drowsy on day 7. What could be the possible causes?
Hydrocephalus.
Very good. So one is hydrocephalus. What could be the other cause? You missed viral co-etiology. Because the CSF dragged us to a picture of pyogenic meningitis, this patient may have developed encephalitis later on. So, whatever it is, you will repeat an MRI. And in case of tuberculosis, tubercular meningitis is also type of pyogenic meningitis only. The patient may have cerebral vasculitis despite steroids. Sometimes the steroid dose required in tuberculosis could be as high as 16 milligrams 3 times a day, just to suppress the vasculitis. Okay. So if the patient becomes drowsy on day 7, you should rule out possible non-infective causes like hydrocephalus and infective causes like new onset encephalitis or mixed viral etiology. Is that okay? So why I am saying it, even if you don't do anything and this patient came late to you, you have a patient who has a history of fever and altered mental status since 2 days, fever plus headache and altered mental status for 2 days. Another patient I have fever plus headache for 10 days, altered mental status for 1 day. What is the difference between these two? Any idea? This patient most likely has encephalitis. So altered mental status is presenting complaint in encephalitis. However, altered mental status is terminal complaint in case of meningitis. Did you understand? Have you understood? Yes? Everybody?
Yes.
So if the patient gives history that he had headache yesterday and today he's altered mental status, confused and drowsy, the answer is most likely encephalitis. And if the patient says for last 10 days he was having high grade fever, headache, photophobia, he was fine eating but having vomitings, but only today he had become drowsy. This is meningitis. And anything in between is meningoencephalitis, both of them involved. It is herpes simplex. Okay?
Doctor, can you repeat it in simple? Just again, like this, to clarify, like headache, if the short course, it's meningitis, right? Short course is encephalitis.
No. Say again. Say.
Like,
If
just
it
can
is
you
a
repeat
short
it again?
course,
This clinical benefit.
yeah, I will repeat it again. If it is a
Sorry.
short course, it is encephalitis.
Encephalitis.
Short course means presenting short course of altered mental status, like progression from headache, fever to altered mental status is only 2 days. Whereas progression from headache, fever to altered mental status in 10 days is pyogenic meningitis. Progression from headache, fever to altered mental status 30 days, it is tubercular meningitis. Okay, this is just hints for you to capture in the exam.
Short course, encephalitis.
Okay. Okay. I ask you still a longer thing. Headache and fever, 6 months altered mental status. What is the diagnosis?
Tubercular meningitis.
Oh,
Patient may have Lyme's disease. So they may say 6 months back, the patient went to the jungle, did a camping, had fever, headache, some rash, and now the patient slept last night very well, is not waking up. So very well, this patient may have Lyme's disease. Okay? Okay?
Okay.
Great. Do I need to repeat it again? Or have you understood?
Understood.
Very well. question number 4. A 30-year-old male patient of HIV/AIDS, CD4 count of 50, admitted with 2-week history of progressive dyspnea. This is a giveaway. Everybody knows the answer. Non-productive cough and fever. Oxygen saturation 85. Chest X-ray shows diffuse interstitial infiltrate. What is the diagnosis?
I forgot the name. PCB, yeah.
What is the latest name of this organism?
Zerovitsi.
Polycystic gyrovasai.
Current.
So pneumocystis jirovecii. Okay. So you have diagnosed that this patient has what is the diagnosis?
PCB.
What PCB?
Pneumonia. Pneumocystis jirovecii pneumonia.
Okay. So this patient has pneumocystis jirovecii pneumonia. And how do you diagnose pneumocystis jirovecii pneumonia?
Bowel culture. It will not show a high yield in the normal sputum culture.
PCR.
Okay, PCR. That is a long haul.
Silver staining bronchoscopy.
Yes, somebody is talking good. So basically what happens is that this is an organism which is a very twisted organism. Sometimes even X-ray doesn't show anything. Up to 10% of patients' chest X-ray will be entirely normal. I'm like writing in capital letters. Why? Because don't feel that the patient is having normal X-ray and cannot have PCP. Now that means, how do you diagnose? Number 1, SpO2 is low. Let us say if SpO2 is normal. Can anyone tell me what is to be done if SpO2 is normal and given the history of HIV, you are suspecting
Exertional hypoxemia.
Say again?
Exertional
Yeah.
hypoxemia.
Can you name me a test that is done for that? Which we used to talk about so much during COVID.
No.
The 6-minute walk test has been there since ages. And only during COVID time did we come to know about this. What will happen in 6-minute walk test?
PO2 drop.
Hypoxemia.
Yeah, patient will have decreased saturation. And is there anything else that occurred in COVID and also occurs in PCP pneumonia? That is
ERDS.
Happy
hypoxia. The patient is having saturation of 88-90% and they don't feel anything.
They look fine.
That is why, oh, what has happened? That is why one of the diagnostic criteria for pneumocystis pneumonia is PO2 levels less than 70 mm. Because it causes problems with the DLCO, diffusing lung capacity for carbon monoxide. So basically pulmonary membrane is distorted. This is what happens with PCP pneumonia. So what will you do? You will do chest X-ray. 90% will show ground glass pasties, GGOs, or 10% will be a normal X-ray. Number 2, you will do an HRCT chest, which will show us lesions. Third, you will do an ABG, which shows hypoxemia. Hypoxemia out of proportion to chest X-ray. That is why they are happy hypoxemia. Okay?
Okay.
Then number 4, LDH. It is mentioned in the liver function tests. LDH will be elevated. Why? Because this is an intracellular pathogen. It is an intracellular pathogen. Whichever intracellular pathogen like Diplococcus, Neisseria meningitidis, this organism, PCP, they enter into the cell. When they enter into the cell, they break up this plasma membrane and LDH is released. Hence, the LDH increases in blood. So, destructive organisms are these. They destroy. Same for malaria. Malaria also does the same. So, and So how will you identify? You will do sputum. So number 5, sputum or ball. You will check for silver Giemsa staining. Silver
Giemsa staining.
Giemsa staining. And yes, as one of you told, then if you have it available with you, then you need to do a PCR. So my question is, PCR of what? Like in Legionella, we can do PCR Legionella in the urine, like antigen is done in urine. Which sample do you take for PCR in case
Bal.
of PCP? It is, yeah, it is
Microbial batch.
respiratory sample. Respiratory sample. Okay. It may be sputum or it may be ball. Okay. This is how you diagnose this patient. How do you treat?
B.
Antibiotics and steroids.
Trimethoprim and
Steroid and
sulfamethoxazole.
So trimethoprim, sulfamethoxazole combination is drug of choice. Okay. And second, somebody said as very correctly.
Pentamidine.
So no. Let's take
Steroids.
here
Steroids.
yes. So what is, yes, hypoxic. So wherever the PO2 levels are less than 70, you will start the patient on steroids. Okay. Now let's cut the steroids because they are, so two therapies are there. One is antibiotic and the other is steroids. There is a patient I cannot give trimethoprim sulfamethoxazole. The patient supposedly is on methotrexate. What will you do now?
Go for the second line.
Yes, that is
Pentamidine. Also prophylactic for them.
so somebody is sensitive to pentamidine also. What will you do? As I told you, LDH releasing organisms. One organism I told you was, so all the malarial drugs, they work very well in case of PCP. So the
Hydroxy.
other option is clindamycin
Clindamycin.
plus primaquine combination. And now the patient has G6PD deficiency. So what will you do? You cannot use this. What will you do? So you will use atovaquone. I have given you all possibilities. So that is 4th. So patient is on methotrexate, cannot use trimethoprim sulfamethoxazole. You put the patient on pentamidine. Let us say pentamidine also doesn't work. Then you put the patient on clindamycin primaquine combination. Let us say the patient is G6PD deficient. Then you will use atovaquone. Now this is also anti-malarial. It is less effective, but thank God we can use something. Okay. Where do you start prophylaxis for HIV positive patient for this thing?
CD4 less than 200, I think.
No. You are preparing for headache. No thinking. Only knowing.
Repeat the question, please.
So when do you start the prophylaxis for PCP pneumonia?
Less than 200. Yes. Less than 200.
Let us say the patient has no history of CD4 count. He says, I do not have any CD4 count. I will not get it done. Let us say the patient has, because it is the right of the patient to refuse for an investigation. He does not want a CD4 count. What will you do? Will you start the patient on PCP prophylaxis? Very good. So you look for oropharyngeal candidiasis. Oropharyngeal candidiasis. So the thing is that you start the prophylaxis if the patient has CD4 count less than 200 or presence of oropharyngeal candidiasis. That also brings me to a question. Let us say if somebody has a CD4 count of 280 with oropharyngeal candidiasis. Should we start the patient on prophylaxis?
Yes.
What is the logical
response to
answer?
our
Is yes, because oropharyngeal candidiasis is one of the criteria to start the patient on prophylaxis. And what is the dose of prophylaxis? Trimethoprim sulfamethoxazole, double strength tablet once a day. If you cannot use trimethoprim sulfamethoxazole, the other agent for prophylaxis is
pentamidine. I think it's
okay. Dapsone is one. Atovaquone is two. And yes, aerosolized pentamidine is another. Aerosolized pentamidine. Is that fine? So there are
fine.
three main considerations. One is how you diagnose. So that is ball with silver Giemsa staining or PCR of the respiratory secretions. CD4 count less than 200 or presence of oropharyngeal candidiasis subjects the patient to prophylaxis. And the drugs involved are trimethoprim sulfamethoxazole. If you cannot use them, the next drug is pentamidine. Cannot use, then you can use the combination of clindamycin and primaquine. If you cannot use that, atovaquone is the reply. For prophylaxis, dapsone is another drug which you can give if you cannot give trimethoprim sulfamethoxazole. Is that clear? Next question. A 72-year-old man. I think with this rate, we will not be able to do neurology. If the First Academy guys are okay with it, we can just finish with infective diseases only. A 72-year-old man presents with a history of severe diarrhea, fever, abdominal pain, treated with clindamycin for dental abscess. A stool test confirms presence of Clostridium difficile toxin. What is the best initial treatment?
Vanco, oral.
Okay.
Vancomycin, orally.
The flagyl. Start with flagyl. Oral vancomycin you will give
Metronidazole.
patient not responding to flagyl.
So
No, first line is vancomycin, I think.
there is severe diarrhea, so you have to classify. Okay.
Severe diarrhea. Should I upgrade the Vanco or should I switch?
Let's go to Vanco.
Vancomycin,
Because,
oral vancomycin.
yeah.
Yeah,
Yes.
even if it's severe, we
Yes.
can
So,
say 500 if severe, but that's still
yes.
first line therapy.
So what kind of an organism is C. difficile? So it is a spore forming organism. So we need drugs which can enter into the spore and kill it. It is very important that there are very few drugs which can do this job for us. It is a gram-positive bacteria, so that opens up the gate for vancomycin. So spore forming gram-positive organism usually grows as a preferential bacteria when antibiotics are given. Every other dies, so this stays back. So this lives, everything else dies. So major cause of antibiotic associated diarrhea plus colitis. This is very important. Antibiotic and associated diarrhea is something else. Colitis is different. Okay. So what it produces, how do you diagnose it?
Toxin.
So basically it produces two types of toxin, toxin A and B. Toxin A is known as enterotoxin, which causes diarrhea. All spelling wrong. So this is enterotoxin, which causes diarrhea, and the B is cytotoxin. It damages the mucosa. So when the colonic mucosa is damaged, so that is when colitis happens. Okay. Usually antibiotics which cause this is clindamycin. Clindamycin is the most notorious drug. Otherwise, all antibiotics can do the job. Otherwise, regular use of proton pump inhibitors also increases the incidence of C. difficile infection. Watery diarrhea, Pseudomonas colitis. So how do you diagnose? You diagnose with the toxins. Let us say if now EDIC people, they can ask you some new questions. So there is another test which is called a screening test. Screening test is the initial test always. So you do that. That is called GDH. That is glutamate dehydrogenase test. This is used for screening only. Okay. So finally, the diagnosis is either via toxin assay, as you said, or it can be used by the PCR. If the patient does not have colitis and pain and is not very sick, you can do colonoscopy and look at the colonic mucosa if it is a pseudomembranous. Have you ever seen pseudomembranous colitis photo? No? Ever seen pseudomembranous colitis?
Yes.
So basically it is like banana peel scattered here and there on the floor. It actually looks like that. Okay. So the treatment, now I'm going to give you guidelines. Guidelines are mild to moderate disease and severe disease. Even in mild to moderate disease, the drug of choice is oral Venco or fidaxomicin, new drug, distant congener of rifaximin. Severe disease, again oral Venco, or if it is fulminant colitis, then IV high dose Venco, because it will not go into the GIT intravenously, plus IV
vancomycin pulse therapy.
Yes, so that is recommended if the patient has severe colitis and not holding back. So oral medicine may not work. Okay. So if it is a recurrent colitis, then it is long duration Venco or fidaxomicin. So metronidazole intravenously is recommended only in cases of severe disease, and that too intravenously along with intravenous vancomycin, also known as pulse therapy with vancomycin. Okay. Shall we move to the next question? So the answer is yes. Oral vancomycin. Metronidazole is alternative but less effective. Oh. Can somebody read the question, please? I'll take water.
Well, a 60-year-old man is admitted with sepsis due to a urinary tract infection. He has a history of aortic valve replacement. So blood cultures are positive for Enterococcus faecalis. Which of the following antibiotics is the most appropriate for treating this patient's infection? So we have a patient with sepsis, UTI, aortic valve replacement, Enterococcus faecalis.
Yes.
Leave the rest to you, doctor.
So what do you think is the answer?
Vancomycin or ampicillin?
Vancomycin, because of the prostatic valve, I think.
Okay, so what are the guidelines on this? What is the answer?
I think they say gentamicin, vancomycin, and I think benzyl penicillin or flocculoxacillin.
Okay, so basically there are few things which are very important. One thing is, how does Enterococcus faecalis go and affect the aortic valve? Can anybody tell me why it is such an important organism? Why it has been mentioned so clearly here? So Enterococcus faecalis is such an important organism that if somebody has a valvular heart disease and is going for colonoscopy, they require antibiotic prophylaxis. This is very important because this is a bacteria, gram-positive bacteria, which lives in the colon And once the colonoscopy is done for the patient, this organism, it has a tendency, because of its pili and binding capacity to the valves, it goes and sits on the aortic valve preferentially and will lead to aortic valve endocarditis, which is very rare, but is very common with these procedures like colonoscopy and all. Okay. So then, how do you treat? So the treatment basically involves around using ampicillin as the drug of choice. So ampicillin is drug of choice, but if ampicillin is not working, let us say the ampicillin is basically it is empigenta. So this is the combination approved to be used in case of E. faecalis endocarditis, typically for 4 to 6 weeks. It is a very adherent organism, doesn't readily leave the valve. If by any chance gentamicin is not approved for patients with chronic kidney disease, then the answer is MP ceftriaxone. Okay, and if the patient is not responding, then the answer is vancomycin. And if nothing works, then now that is another option. Nothing is working. What will you do?
Rifampicin.
Leonid.
We will do surgery. Surgery is indicated in uncontrolled persistent bacteremia despite antibiotic therapy. What are the other indications for surgery?
Aortic root abscess.
Very good. Abscess, perivalvular abscess formation,
Heart
systemic
failure, refractory.
Yeah,
heart failure,
yeah,
and
AB.
systemic embolization. Yes?
Speak, doctor.
So that is...
AR, aortic regurgitation due to the abscess and AB block.
Yeah. So AV block, abscess formation, embolization. So these are
Specific
the reasons.
organisms, I think.
And
Also,
when the therapy is not working.
we are treating a case of Achromobacter endocarditis, which I was reading some case reports about it. Nearly everyone who hadn't had surgery has died. So I think also I remember now certain organisms also are indication for surgery, doctor.
Yes, those organisms are also an indication because they will not respond to any treatment.
Yeah.
Yep. So the answer is ampicillin. It is the antibiotic of choice. Empigenta, MP ceftriaxone, not working, vancomycin. If nothing is working, surgery. Surgery is also indicated for abscess formation, distant embolization, and heart failure. Is that clear? So these are quick recap. A 40-year-old woman with no significant past medical history presents with a 5-day history of fever, arthralgia, and a rash. She recently came back from Brazil. Examination reveals a diffuse maculopapular rash with conjunctivitis. What is the most likely diagnosis? So we have 5-day history of fever, arthralgia, and a rash. Looks like a viral disease.
Zika virus.
Yeah, it is Zika virus. Very good. So the presence of fever, rash, arthralgia, conjunctivitis, and a travel to an area with Zika virus circulation is suggestive of Zika. Dengue and chikungunya also present similarly, but they will have more of dengue will have retroorbital pain along with and breakbone fever. This chikungunya will have polyarthralgia, polyarthritis. Conjunctivitis is specific to Zika. Is that clear? I just wanted to have a reference to Zika virus. All right. A 55-year-old male presents with fever, chills, and new onset murmur. He has a history of mitral valve prolapse. Blood cultures are positive for Staph aureus. Which of the following complications is most likely if the patient is not treated adequately?
Heart failure.
Secondary to
Infectious endocarditis.
Say again. Heart failure secondary to. Come on.
I think this
Capillary
can be
rupture.
aortic
Acute
dissection.
MR. Aortic dissection. Don't go so far. It is just a mitral valve prolapse. The patient has, because of mitral valve prolapse, this patient has developed endocarditis. Now, the bacteria will eat up the papillary muscle and it will lead to mitral regurgitation. And it will lead to papillary muscle rupture and acute MR leading to acute heart failure. So this is what you need to remember. Okay. Heart failure, infective endocarditis can lead to valvular insufficiency. Valvular insufficiency. Okay. And subsequent heart failure. A 25-year-old man presents with a 3-day history of fever, sore throat, and swollen lymph nodes. Okay. He reports a recent unprotected sexual contact with multiple partners. Examination reveals oral ulcers and generalized maculopapular rash. What will you do to confirm the diagnosis? What do you think the patient has?
Monospot test.
Monospot test.
Chlamydia.
Rapid antigen for streptococcus.
So acute seroconversion. Have you ever heard?
Yeah, it's a heart failure. They come pretty HIV. They come pretty messed up in the first presentation. Lots of non-specific illness.
So this patient has a history of unprotected sexual contact with multiple partners. He has a full-blown lymphadenopathy. He has sore throat, fever, and a generalized maculopapular rash and multiple oral ulcers. So this question can go in any direction. Monospot test for EBV, you can mark that answer. Streptococcus is out. Throat swab culture will not show anything. This is not a case of strep throat. So the discussion is between HIV test and monospot test. Now the problem is that in monospot test, the patient will have lymph nodes which swollen only the oral, although it is not mentioned anywhere, but this patient has history of intimate contact with multiple partners. So I always tell, and I told earlier also, worst diagnosis first.
Generalized maculopapular rash is a leading point here, Doctor.
Yes, it is a leading point. Given the history, it is a leading point. So you should rule out HIV first. So acute seroconversion presents like this, and HIV antibody and antigen test should be done immediately. Okay. Yes. A 48-year-old male with history of cirrhosis presents with fever, abdominal pain, and confusion. He has ascites. He has tenderness in the right upper quadrant. Diagnostic paracentesis reveals increased elevated WBC count with neutrophilic predominance. What is the most likely diagnosis?
Spontaneous bacterial peritonitis.
Yes. So it is. Yeah. The thing is that this patient diagnosis is a multi-line diagnosis. This patient has hepatic decompensated cirrhosis. So I don't. If you look at from all angles, no, this patient has decompensated cirrhosis.
Yeah.
Decompensated COL with hepatic encephalopathy due to SP. So whenever sometimes, because somebody can stand up and say why it is not hepatic encephalopathy, you are mentioning the patient is confused. But hepatic encephalopathy is a arbitrary disease. Why? Because it can occur because of multiple factors. Somebody having hypokalemia will have hepatic encephalopathy. Somebody having hyperammonemia will have hepatic encephalopathy. Somebody having just low-grade fever will also have hepatic encephalopathy. Somebody who took some sedative, maybe painkiller, maybe pregabalin, also goes into hepatic encephalopathy. Who is constipated also gets hepatic encephalopathy. So who has bled inside because of the variceal bleed can also have hepatic encephalopathy. So the diagnosis is what has led to it. So what has led to the hepatic encephalopathy here?
SBP.
SBP. Wonderful. So how do you diagnose SBP?
Acetic tap showing more than 250 of neutrophils.
Okay. And how do you treat it?
Cephalosporin, cefotaxime.
Okay.
And prophylaxis with fluoroquinolones after.
Fluoroquinolones or?
Albumin.
Why does SBP occur? Let's go into something like that. Why does it occur?
Low protein in the acidic fluid is a risk as an indication for prophylaxis. So
okay.
Maybe.
Okay. So basically what happens is, this is liver, this is healthy liver, and there is a portal vein that crosses through it and reaches the inferior vena cava. You all understand this? Okay, here is a spleen. We all understand this? This is coming from all the intestine and all. Okay. Now what happens in cirrhosis is, this liver which is looking so healthy becomes nodular. This is my own way of teaching. This may not be correct version, but it leads to understanding in a very, very nice manner. So can you see what has happened here? So, what has happened here? So basically what has happened here is that because of this liver gripping up the portal vein so hard, because it has become shrunken, the portal vein fills up with blood. Now, wherever this blood is coming into the portal vein, from wherever it is coming, from the esophagus, these esophageal vessels, they drain into it. They also become inflated. Spleen also gets enlarged. The splenic vein also becomes big. The whole of the colon, whole of the intestine becomes edematous. Why? Because it is just like strangulating somebody. The eyes pop out, the brain becomes edematous, the tongue gets swollen, the face becomes red. This is what happens when somebody strangulates, right? So here the portal vein is being strangulated. So whatever is draining into the portal vein will also become strangulated, dilated. So this is why the varices, they bleed. This is why the oozing happens of protein. This is why the colon is always edematous, and we know this is the cellular basement membrane barrier. So when there is edema, this becomes like this. And what will happen is bacteria, they will translocate. Yes, because of the edematous intestines, the bacteria will translocate from colon into the free space of the peritoneal cavity, into the ascites. And because there is so much of protein, it is a party time for them. They will eat up protein and multiply voraciously. And one day they will lead to peritonitis. Hence, it is called spontaneous bacterial peritonitis. Is that clear?
Yes, sir.
Yeah.
I hope I could get it across well. So that is why all of the problems are with portal hypertension. Portal hypertension is there. So nowadays the treatment is based on treating portal hypertension. You just keep the portal pressures low, as low as possible. The patient will not have any complications. Okay.
Okay.
So this patient has fever, abdominal pain, confusion, ascites, blah, 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 and which is a common complication of cirrhosis. Which are the bacteria commonly involved? So E. coli and Klebsiella. Because why? Because they are
Klebsiella.
Yeah. Why? Why E. coli and Klebsiella? They are Enterobacteriaceae. Yes. They are living in the colon. So they are the ones which can go there. Another bacteria, again, Enterococcus faecalis can go. Streptococcus is present everywhere, so it can go. Okay. So what is the TLC cutoff?
250.
So more than 250.
More than 250.
And what is the SAG cutoff?
1.1.
More than 1.1.
11 or 1.1.
So many times what happens is my students, they tell me, sir, we forget, was it more than 1.1 or less than 1.1? So
Everything
how do
is
you
more.
remember? Yeah, exactly. Everything is more. So you write down in one page, TLC, protein, LDH, SAG. You mention all of them. And all you need to do is do this. And all of whatever you remember, just keep writing there. Okay? So you will never ever forget or get confused in the diagnosis of SBP. Because if you go into SAG, serum albumin, serum ascites albumin gradient, was it more than 1.1 or was it less than 1.1? Remember, everything is more in SBP. So the treatment is based on number one, empirical therapy, number two, definitive. Empirical therapy, cefotaxime, everybody told. If not working, ceftriaxone, alternative. Okay, otherwise piperacillin, tazobactam, etc. you can give. Okay. A 35-year-old man presents with fever and headache and a stiff neck. He also complains of sensitivity to light and nausea. Lumbar puncture done, shows slightly elevated proteins, normal glucose, predominance of lymphocytes. What is the answer?
HSV.
So this is viral NSAID unless proven otherwise. Okay. So this is viral meningitis and herpes simplex can be common. 68-year-old male with COPD admitted to ICU with severe CAP. CAP is community-acquired pneumonia. He started on appropriate antibiotic therapy, but his condition gets worse with increasing respiratory distress. Need for mechanical ventilation. What is the next step?
Steroids.
Anyone? Wonderful.
Steroids.
Absolutely correct. Spot on. So the answer is addition of steroids. No benefit of changing antibiotic because now bacteria will not be found. Even if you do a ball, you will not find anything. You need to cut down on the inflammation. This is patient going into ARDS. So this is addition of steroids. Severe pneumonia requiring ventilation, addition of steroids may help reduce inflammation and improve outcomes. A 50-year-old male, recently diagnosed with diabetes, presents with fever and painful swelling in the groin area. He has erythema and swelling over his right thigh and a fluctuant mass in the right inguinal area. What is the appropriate treatment? So what is the diagnosis? My spelling are also
Abscess, incision and drainage.
wonderful. So take the full name of this abscess.
Right inguinal abscess.
Wonderful. So this is right inguinal abscess. Why does it occur? So there are lymph nodes there, okay? So it is a lymph node which gets destroyed and becomes an abscess. So what is the treatment? What will you do?
Incision and
control.
So we will do the source control. We will do the source control.
IND. IND.
Yes, IND. B is the answer. So the answer is IND. A 70-year-old man with history of ischemic heart disease comes to ICU with fever and altered mental status. Recently underwent cardiac surgery. Blood culture grows methicillin-resistant Staph aureus MRSA. Now the antibiotic of choice is
Linezolid. Sorry, vancomycin. Vancomycin.
Yeah.
Yes.
So if you need to discharge the patient after the patient gets better, you put the patient on oral medication will be linezolid. Okay.
Linezolid. Yeah.
Yeah. So on discharge, you will add linezolid. 32-year-old woman comes with high fever, chills, and severe pain in her right leg. She has history of IV drug abuse. Oh my God. She's just 32. She's IV drug abuser. She has high fever, chills, and severe pain in the right leg. Right leg is swollen and tender. What has gone wrong here? What has gone wrong? She has injected into her
TVT.
No, injected into her femoral artery or popliteal artery wrongfully, because she's an IV drug abuser. She has lost all veins. She's trying to find, so they end up injecting into their popliteal veins or popliteal artery or femoral vein. And what happens is this is right leg is swollen, red, tender with bully formation. Let us say if bully formation was not mentioned, I would have agreed to your diagnosis of DVT. But now I will not agree to your diagnosis of DVT. This is necrotizing fasciitis. Unless you act fast and hard, you are going to lose this patient. Okay? So we have done this thing. Do you want to discuss little necrotizing fasciitis? It is important
Compartment
from your...
syndrome.
Say again?
Compartment syndrome.
Yeah, compartment. So many times you just have to cut open the compartment, and sometimes amputation also needs to be done. So it is a very, very deadly disease. Unless you treat fast and hard, this patient is not going to survive. This sepsis will lead to death of this patient. There is a in EDIC sometimes they ask about HBOT. Any idea of HBOT?
Hyperbaric oxygen therapy.
Yes. So hyperbaric oxygen therapy is indicated in management of necrotizing fasciitis. That is very, very
But that was
important.
for type 2, no, doctor. Necrotizing hyperbaric oxygen therapy for type 2.
Yeah, that I agree. But then whenever there are chances, even in type 1, if there are chances that the patient is going to, need an amputation before anything, you can add on hyperbaric oxygen therapy to the patient. Okay?
Yeah.
Thank you.